Second class.
Just 1 second.
Virtual.
Recording start. 1 second, sir. Recording has started. Yes, sir. Yes, sir. Go ahead, sir.
Welcome back to the second class on virtual echocardiography and ultrasonogram and neonatology. I welcome our speaker today, Professor Dinakara sir, who has taken a lot of efforts, especially after the first class. He has sat almost at midnight yesterday, and he was working on the invitation and also on the camera and other things. And today's topic is going to be patent ductus arteriosus PDA in newborn. Sir will also give a short recap of what was happened in the previous class, so that you can refresh on the topic on basic the probe, transducer, how you move the probe, what are the various planes, what are the various views. He'll give it a short gist of all that that was taught tested last class, and subsequently he will switch on to the topic on PDA. Unfortunately, we have no typical PDA baby here. Probably he has got a just born baby where if there is a PDA, there will show it to us, and he will show. Otherwise, he'll show a very sick baby with the PDA. Let us hope we get a good view of the PDA in the just born baby. And without any delay, I would like to hand over the thing to the speaker, Professor Dinakara sir. Over to you, sir.
Yes, sir. Thank you very much. I just outside, I want to thank once again to the ICH, all the professors and NNF Tamil Nadu, Emma, Chandran, Lakshmi, and once again Kamal sir and my friend, very good, my friend Vaideshwaran. And at the same time, I really convey my thankful and gratitude to Prashant Gowda as well as Aman and Genworks, especially Genworks, Mr. Ganesh and Anviti, because yesterday almost at 6:45 to 7 o'clock we gave that brochure. They sat till 11:45. 12 o'clock it has done. Okay, and they have done it in a good way. Thanks to them, and they are going to give us a very high-end machine for the ultrasound for the record, such that from another 2-3 classes live, whatever we do the live, it will come like in virtual like that. So they're going to give that machine, that because that equipment it's not available at present in complete India. They told it was available in Bombay. Now we have ordered in Amazon from US. It's going to land to India on 8th of this month, probably on 10th or 11th, 12th. We are going to show that. Thank you, Ganesh. Thank you, Prashant and Aman. And let me go to the basics. Yeah, I think so. Many people have asked us. Yeah, many people have asked us, sir, can you just go revamp the old things? Yeah, I'll try to show. If you don't know the basics, so you cannot hold how to catch the PDA, how to put the probe, all those things you should be very careful. Number one, this is the heart. I'll take only 10 minutes. I'm seeing the watch. This is the heart. The anterior portion of the heart is covered by completely right ventricle. Even right side, it is covered by right ventricle. Right atrium is most superior at the base of the heart.
Just sorry to interrupt. It is not visible.
It is not visible.
Yeah.
Now, is it visible?
Visible, sir.
It's okay now?
Nothing happened. Now it's visible. Yes.
Make it full screen, sir. Visible. Yeah.
Full screen.
PowerPoint, sir. PowerPoint. Slide.
Now 1 second. Can you see, sir?
Yes, sir. Now it is visible.
Yes, sir. Now it is visible.
Only thing we have to make it as bar right, sir. PowerPoint. Yes.
Okay. So this is the right ventricle. Anterior portion is covered with the right ventricle. And superior base, what we call the base is where the blood vessels will arise. We call anatomically base of the heart. Apex is where we see the tapping apex bit or whatever it is, it's apex. So number one is over. Number two, right atrium is the superior most and right side of the heart. left atrium is posterior most, remember. So that is the one. Then the same thing, it is like overlapping. That is the reason you should know what you mean by overlapping in the echo. Okay, this is all the inside of the heart valves, like a doors in the house. So number one, most superior portion anterior is pulmonary. Then if you'll come to the little down posterior side, it's a tricuspid. Then go to the little posterior, it is a mitral. Sorry, aortic. Then go to the posterior, it is a mitral. So once again, I repeat, anterior most, near where we keep the hand on our chest, anterior most is pulmonary artery and pulmonary valve. Just go to the posterior is tricuspid towards the right. Then if you go more posterior, aortic valve. Then if you go more posterior, it is mitral valve. So mitral valve is situated almost posteriorly in the according to the valves. Okay, number come. This is the place where we are going to keep the probes. Subcostal, apical. Instead of remembering left, right and left parasternal, remember parasternal, long axis and short axis. That's enough. Suprasternal. Then at least you should know this. What is transducer? Sliding, rotating, tilting, rocking. Remember, tilting means how we ride the bike, tilting. Okay, rocking means anterior, rock, anterior. Then rotating is like this, rotating. Then transducer sliding, going that side, going this side. So these are all the positions. Then subcostal, first please see the aorta. It should be always left side of the vertebra. IVC is towards the right side. If you know that, that's enough. Please see the liver. It should be on the right side. Stomach should be on the left side. Then that's it, because I am going very short. Please see this. Parasternal. This is okay. First we will go to the subcostal. Subcostal means below the xiphisternum. How you are going to keep the probe? That round one, what you are seeing is a probe marker. Probe marker. That is very, very, very important. When you are seeing the short axis, SVC, IVC, it should be like this. That downside, because if you try yourself, you will come to know. First, what your superior most and right side is superior most. Once again, superior and most right side, how you are going to keep the probe like this is the SVC. Then come to the LVOT, then come to the RVOT, then come to the apical view. Long axis also same thing. If you don't remember what you should see, it is very difficult for us. So this is once again, sorry. Come to the apical view. Always try to go from posterior to the anterior. Sweep the, that is called tilting the probe or tilting the probe. Tilting the probe from posterior to the anterior. That is good. Parasternal also. Parasternal needs slightly tilting as well as slightly rotating. Remember, parasternal needs slightly tilting as well as slightly rotating. Even long axis also. Long axis is purely tilting. So in the long axis, when you keep, that is called a standard view. Okay. Then if you will turn your, in the parasternal long axis view, if you will tilt your probe towards the right hip, you will see the tricuspid. If you will tilt your probe towards the left shoulder, you are going to see the pulmonary. Same thing, apical and suprasternal is a beautiful. Okay. If you are a beginner or something like that, you will feel very happy if you will see the things. See, this is the one, how the heart is going to look. I'll show you very fast. I have only 3 minutes for the long, this thing. Just see this. I told you from the posterior, we are going up. Here, in the image it is showing from anterior come down, whichever the things, it doesn't matter, but always try to go from posterior to the anterior, because 90% you don't miss, and even in this you don't miss, but I have tried like that. Why all these angles? If anybody asks, in the congenital malformation, congenital, whatever the disease is there, if you know all these things, 99% you will find the from normal something will be deviating. Then you will find, oh, something will be there. But one thing remember, you should know the basics, you should know the theory, you should know from where blood should go from that side to this side, whether gradient. Then only, if your brain doesn't know, eyes cannot search. Number one. So this is an apical chamber. Once again, like putting an axe and lifting it from posterior to the anterior. So this is the whatever the things, parasternal or suprasternal, everything. This is a parasternal long axis view. See in the center, what you are able to see. Control and so you can see this. This is the normal standard. If you will tilt, you will see tricuspid valve. Sometimes in apical view, you are not able to get the tricuspid regurgitation. That time you are supposed to use this. Why it is important? And in sometimes, if you want to know the parasternal, this view, if you are not getting in a short axis, this view is more better. Why this is better is, even in the TGA or anything, if you will find this, so you can rule out the TGA. This is very important. Everybody knows this. Okay, this is the standard view. This is converted Mercedes Benz or cup, and this is a cup. This is a saucer. Cup and saucer. So this is all the things. You can only one thing what I want to tell you is, you will go in. So once again, in the parasternal long axis view, just you are tilting, rotating the probe towards the 12 o'clock to 1 o'clock and sweeping, not sweeping, angulating anteriorly. That is the thing today's talk. PDA, where you are seeing MPA branches. Once again, let me repeat. In parasternal short axis view, once you see, just rotate the probe from 12 to 1 o'clock position, tilt your probe, or not tilt, angulate superiorly. Just angulation means like this. Angulate the probe superiorly, where MPA you are opening the branches. There you can find the aorta. That is called the PDA or ductal view. Usually everybody will say this is a ductal view or high left parasternal view. High left parasternal view is for the ductal view. So remember this. This is our talk today. Then this is a suprasternal. This is a long axis. Somebody is telling to see the SVC. SVC means this. So this is the one. Some people are telling high right parasternal. So you need not get confusion. Sir, suprasternal. Okay, suprasternal.
Bad conditions, scleroderma.
There are 1, 2, 3 slices are there.
No use.
Suprasternal means you need not keep the probe in the sternal notch. You can keep it in the left side and angulate towards the right. You will see SVC and right atrium. Keep it in the same place. The probe marker towards the head. Tilt slightly, you will see aorta. See, this is the one. In the first, what you are calling right high parasternal. So instead of you getting suprasternal 3 cuts. One is SVC cut, another is arch of aorta cut, another is MPA branches with PDA. See, this is today's my talk. So you can see the PDA in suprasternal third view and high left parasternal or short axis, just one more view. Like that you should remember. Then can I see the PDA in other views? Yes, you can see the PDA even in subcostal view. You can watch the PDA, but can I measure? It is difficult, but measurement of the PDA should be done in the ductal view. That is called left high parasternal view. Then can't I measure in the suprasternal? You can do it. In case if you are having doubt, you can do here also. So this is the views. Hi, this is my talk today. What I am showing. So this is the SVC view. See this, how it is angulating and tilting and beaming towards the right. Then come to this. See, it is slightly I tilted. Sir, not tilted, rotated my probe. Then in the same place, I am angulate. This is the PDA view. If you are confusion, see this. But if you are not finding properly, just try to rotate the probe and never fix it. 12 to 1 sir told, so I am going to place it. So, and apex means you don't need, just keep searching where is apex. Okay, that is very important. You need not fix to the numbers. This is the one, even for our talk today, it will be useful. Or apical view also useful to see the pulmonary veins. This is the pulmonary veins where you are seeing right, upper, lower, left, upper, lower. This is called a crab view. Okay, my talk is over. Okay, this is, sorry, I took extra 4 minutes for my basic talk. Now I will share to this. I think so you people can see my PDA talk. Anybody can see my PDA talk right now?
Yes, sir. Yes, sir. Go ahead, sir.
Okay. So sorry to say this. Now I'll start the PDA. See, I don't want to talk for an hour because it is a virtual talk. 3 o'clock, I'll finish my talk. I'll show, try to 45 minutes to 1 hour. I'll try to show what you have to see.
Okay.
And I request everybody, dear friends, dear students, dear seniors, in case if you are really interested, your thought or flow thought and your paper pen is very necessary. Because if you will hold your breath and your thoughts with my flow of talk, 100%, 20 minutes you can learn the PDA. I'll make it very easy. Many other things, what even in theory you are going to get, I'm going to answer. Okay. Please, if you have the snap, if you are seeing in a mobile or something, do the snapshot. I'm going to talk only 3 parts. Only 3 parts. PDA. A, B, C. Then pulmonary overcirculation. A, B, C. Then systemic shunt. There also A is there. I can mention aorta, iliac trunk, middle cerebral artery. There also A, B, C. So 3 points, 3 points, 3 points. Easy way to remember. Why? Sir, I will see the PDA diameter. Can I tell? No. Sir, I have seen the diameter. So I will, in the second part, I'll take only LVO. Can I tell hemodynamically significant? No. Sir, can I tell pulmonary systemic 1? No. Because to tell hemodynamical significance, there are a lot of people have studied it. And they have made a score, PDA score. That is little different than this. But however, in these 3 points, you should have a PDA diameter 100%. Number 1. PDA should be there. And diameter is very, very important, dear friends. One word. Then flow. Yeah, once you will put the color flow in the PDA. Remember, there is a channel is there. Whether the blood is flowing from the left aorta to the pulmonary, that is called left side to right side, or blood is flowing from the pulmonary to the aorta, that is called right. So whether it is bilateral, bidirectional, left to right, right to left. So what is there? Okay, that is, sir, I have seen bidirectional. Sir, I have seen purely right side. Sir, I have seen purely left side. Suppose if you see bidirectional, what you should see? What I have mentioned, please read it. With bidirectional with right to left shunt is less than or more than 30% of the cardiac cycle. It is a significance. If the right flow is more than 30% of the cardiac cycle, that means pulmonary arterial pressure is more. Once again, if you will see the bidirectional flow, I'll show you. If you will see the measurement, so right side is more than the 30% of the cardiac cycle. That means one more thing, remember, pure right side is always dangerous, dear friends, because it could be TAPVC, it could be pulmonary vein stenosis, or it could be some congenital problems. Okay, that is the reason. Sir, suppose if it is a bidirectional, that time if the right side is more than the 30% of the cardiac cycle, means one cardiac cycle, systolic, diastolic. Okay, that means right to left, left to right, right to left. If that right is more than the 30% of that, whatever it is, if it is 100 milliseconds, if it is a 40 milliseconds of the right side, that means you should still think probably duct dependent cardiac problem. So this is one, not only pure. This is one you people remember, dear friends. Okay, 2. Then velocity. I will show you what you mean by velocity, because it is very, very important for the neonatologist. Means neonatologist performing echocardiography in the point number 1, C is very, very important, because whether this is the time to treat or not, or whether it is started closing after the treatment. So C point is important. I am going to tell you. So please memorize whatever I told you in the A, PDA diameter. Okay. Then flow direction, whether left to right, right to left. In that 30% is important. Another is what is this flow. Then come to the other one, pulmonary over circulation. Suppose if the left blood is flowing, more blood is flowing from aorta to the pulmonary, whether his lung is overloaded. So from lung, where the blood should come? It should come to the left atrium. From left atrium, it should come to the LV. From LV, it should start flowing. So that is the reason cardiac output. If that cardiac output normally 170 ml per kg, it should not go more than 250 in a preterm. Suppose if it is started, it's usually 2. Suppose if it is started rising more than 250, you should have a caution. I told you diameter, flow, velocity. Then LVO started increasing. So I will show you what is. This is a must. Cardiac output is a must with the diameter. Next. Okay, sir, I have seen the cardiac output is raised. Come to the volume. Blood is started coming to the LA. LA started stretching. LA means left atrium is increased in the diameter. So we should compare LA to the AO. Then only we will get that. I'll tell you what is that. Remember 1.4. If the ratio of LA is to AO, if it is more than 1.4, remember 1.4, then it is dangerous. LV-EDD, just it is once again depending on the PFO or AST or PDA once again, but people have studied it. Leave it. Pulmonary, that also leave it. I'll tell you what is D wave. Nothing to worry. So LVO is finished, LAAO is finished, then left pulmonary artery. So from the main pulmonary artery, there are two branches are going to divide. One is towards the right, another is towards the left. Because PDA starts arising from the bifurcation place, but almost near the LPA, left pulmonary artery. So if the PDA is there, blood will come from the aorta to the through the PDA to the LPA maximum. So what happens? Once the diastole time blood will start coming, that time diastolic turbulence is there. Our diastolic flow will increase. That I'll show you today. That is one. Should remember what is left pulmonary artery. Diastolic means during the diastole from the aorta, blood is started flowing through the PDA. It flows into the LPA during the diastole time. So diastolic volume in the LPA will increase. That's it. Then, okay, sir, you told me volume load. So it is all becoming big and volume is flowing. What about pressure load? So do you think LA can tolerate that much pressure? Because blood is started flowing like now everywhere rains are there, dams are started knowing that pressure, so it will open up. Or people will open the things, how the water will flow. So that is called mitral early and atrial contraction, EA. Today I'll show you what is it, how to take it. Then how to take it is very important, because all these things, if you will know this, then sir, I have seen diameter, you told me I have seen. C, I have seen. Then A, you told me very important, I have seen. LAAO, I have seen. LPA, I have seen. Mitral EA, well, that IVRT, that also I'll show you. That's called isovolumetric relaxation time. That also I'll tell you what is relaxation time, because LV needs some relaxation time after the systolic. Since LA is having more blood is coming from the pulmonary veins, the gate will open up. Gate means mitral valve will open up. So it won't allow the LV to relax. Because of PDA, blood is coming to the pulmonary to the, lungs to the pulmonary vein. It has to go to the LA. It cannot hold, mitral valve cannot hold. So it will open up the gate. So relaxation time of the left ventricle will come down. It should be more than 45 milliseconds. But it starts coming down. As it starts coming down means it is dangerous. So very clear. Come to the last. Sir, PDA is there. Left ventricle is pumped. Blood is going from the ascending aorta to the arch. Then go down. When is going down, PDA only during the diastole, it sucks the blood, everything. So blood is not able to flow during the diastole to the lower body, like descending aorta. Then to the SMA, renal artery, celiac artery. Suppose in the brain, if during the diastole all the blood is sucks in the PDA, what is this? What is this? So left subclavian or right subclavian, what is there? It will divide into the anterior cerebral artery. So middle cerebral artery. What happens in ACA? Blood will, during the diastole, it goes back. Instead of full diastole, full systole and diastole, full systole and diastole will come down. That is called stealing or absent diastolic flow. If more big PDA, it will go back. That will show reversal diastolic flow. So that if you know, this is the talk I am going to tell in 15 minutes. This is all theory. I think so. You people are more better than me. However, 15 seconds, please go through. We are all worried about this. Because of the PDA, we should not lose the baby. So we should diagnose when to treat the PDA. That's what today's class is. And at the same time, if the blood is not going to the gut, NEC, IVH, all those things will occur. Suppose long time blood is flowing, if there is no pulmonary hemorrhage, it can go on the ventilator with BPD, with infection, so many problems. So two things. One is systemic stealing, another is pulmonary over circulation. So over is more dangerous, stealing is also more dangerous. So come to the 1, 2, 3. Now come to the 1. Please remember, if you have a snapshot, please take a snapshot. If you will see this, it's enough. Come to the diameter. So where is, how to see the ductal view? See, this is the view. What in the image showing is high suprasternal ductal view. So if you will keep if you will keep this one slightly somewhere here and superiorly placed, so that is called a ductal view. Now come to the next slide. If the ductus is patent, two views I was telling, from the parasternal short axis, slightly rotate from 12 o'clock to 1 o'clock, slightly slide one rib upper, angulate superiorly. Once again, I repeat, after parasternal short axis view, don't move the probe, tilt the probe 12 o'clock to 1 o'clock position. Marker should be towards the head. Superiorly tilt. Okay, 99% that is called a just move, slide. There are three things: sliding, tilting, angulation. So it is not a difficult. Once if you will see, you yourself will do. I am telling, dear friends, once again you do it, it is easy. You will find this one, you are going to find. This is called a ductal view. Ductal view. BP. Ductal view. So suppose parasternal third view. See this, how I am seeing. You will find this is an MTA divide. See this is the view. Many people will get confusion with this. If you will see, you will get it. Sir, one thing everybody I am telling you, minimum 250 basics views if you will do, and if you will know that little Doppler, and you will become little master. If you will see 500 cases with the Doppler and with shunting and the gradients learning, almost you will become a master. So basic master, higher master. If you will see 1500 cases and diagnose more than 100 congenital heart problems, so 1500, you will become a core, means neonatologist, echocardiographer. Till that time, please, you should not, whatever you will do, you should not be overconfident. And one more thing, I request everybody, what neonatologist we are learning, it is for the point of care. We should not jump, it is there, I will do it. It is point of care to save the baby. If you find it in the midnight, if your cardiologist is not available, you can go ahead and treat, write in a case sheet, screening done. Inform to your senior, screening done, this is the there. Then seniors will help you. That I am going to tell you, oh sir told screening done, I will do it. Overconfidence. Then PDA is there. If you would have closed PDA, baby would have been dead. Then he thought it's a PDA, but the problem was different. Okay, so but taking the cardiologist opinion, pinning in the pen down in the case sheet, always safety for in this medico-legal era. Come to this. Sir, how to diagnose PDA? Please, dear friends, see this. This is parasternal short axis view. This is RVOT. This is MPA. This is duct. This is RPA, LPA, means right pulmonary artery, left pulmonary artery, duct. Sometimes what happens, the blood is flowing away from the probe. We found if it is a pure right to left shunt, many people have missed it because there is no PDA. How it can be TAPVC? TAPVC will have sometimes pure right to left shunt, but they are thinking this is an MPA, part of MPA. Remember, that is the reason. Have patience. See, I am showing you, this is RPA, this is LPA, this is P. Please see this. Once again, you people can see. This is the one, MPA, RPA, LPA, PD. Okay, please see this. And sir, how to measure? Don't put the color first. Don't put the color. If you are a beginner, please see this. I told you high, right, high, parasternal, angulated view, where we call it as an left, high, supra, what is it, parasternal view, ductal view. If you are finding, you should measure it from the pulmonary artery side, not towards the aorta side. Otherwise, wherever the, if you are putting the color like this, then increase the color gain. See that color gain, that unleashing effect will spread, go out of the vessel. Then start decreasing the color. Start decreasing the color. You will find I am decreasing more. So I can see the PDA there, but my color is here. See, I can see the PDA. PDA is this much. See, example here, my PDA is here, but my color is till it has come here. That means you slowly start decreasing. Appropriate, you will get it. Suppose you are a beginner. Increase the color, start decreasing. You will know the black, oh, I started. Then slightly increase, such that the color will fit. Then you measure like that. Then press once again update. Then you will get the measurement properly with color, without color. Because usually sometimes somebody might have put the more gain of the color. So you'll big PDA. Then you will call the cardiologist, sir, it is 1.4. For you, it is 3. So see that. And see here, dear friends, it's purely. What is this? You people know it. Now come to this. So somebody was telling, sir, this is LPA. Where should I measure? So I asked some people, sir, blood this, do you think this is completely PDA, sir? Because my postgraduates have started asking me, is this complete big PDA? No, dear friends. Just what you do is PDA will be minimum at least 1 millimeter, 2 millimeter, 4 millimeter, 5 millimeter, or sometimes tortuous, sometimes conical, sometimes like this, sometimes cylindrical. There are so many shapes are there, 14, 15 shapes. That is different. Normally it is like a duct, this much, around 0.5 to 1 centimeter. Sir, do you think this much is the big PDA? From here to here? No, dear friends, it is not a big PDA. Is this PDA might be only this much. This one is blood is flowing from here to here. It is ejecting. That ejecting is the blood. It from the color Doppler. It is showing towards the probe. It is showing red. So PDA is not so much PDA. Okay, you should remember this is the only PDA, small PDA. So that is the reason we are measuring the minimal. From here to here, it's not. It's only a blood is flowing. Okay, so that is one catchy point, whoever the beginners. Now come. See here, what I want to tell you is, so do you think this much is a big PDA? No, dear. See, this is the smallest, whichever the minimum, that is the PDA. See, here also, this is the PDA. So here PDA is completely right to left. It's a big PDA, big. So I want to take the measurement from somewhere, which is the maximum. I cannot see where is the minimum only. So it's a big PDA. Come here. So see, this is purely right to left. I have to take the measurement from here because this is a pulmonary side. This to this. Not this is a descending aorta. This is the flow of the descending aorta blood. This is the PDA. I think so. You people can see. You can see my cursor too. Come over. Please read this. It's a beautiful thing. So remember, when you are giving either paracetamol, if you are giving ibuprofen, if you are giving, or indomethacin, if you are giving, you should know whether it is constricting or constricted or not. You should know where to measure. That is the reason my words are like this. So come to the direction of the flow. I told you diameter, how to measure it. I'll come to the diameter, what is there, minimum, small, middle, or large, or medium, large. And always try to measure in a pulse wave Doppler. Pulse wave means, please dear friends, you put your this thing Doppler and these two gates will come. This is a pulse, from here only gates. Suppose one line will come straight, dotted, that is called continuous wave. Continuous wave, we do use it in the more than 2 meters per second if the flow is very high jetting, like all stenosis. Stenosed, because blood is flowing very fast. There it will be more than 2 meters per second. There you use continuous wave Doppler. If it is a less than 2, you use pulse Doppler. Pulse means sampling gate, you will get it in your thing. That is where if you are a beginner. So come to the, now I told you right to left, left to right. Fast I'll go because I have to show you. Pulmonary pressure exceeds the systemic, pure right. That means blood is flowing. Systole is the left ventricle is compressed. Same time pulmonary artery also will go, aorta also will go. Okay, but pulmonary artery pressure is more than the systemic. That time during the systole also blood will go to the aorta. Even during the diastole also blood will go to the aorta. So it is purely, see, it is downward. It is downward where you will see the gate pulmonary artery. See, this is the color. Where I am putting the color is a pulmonary color. Systole as well as the diastole more than the systemic. So you understood what you mean by systole and the diastole. Beautifully you are seeing. But here the catch you should see is, see, blood is flowing even in one direction, left, right to left. See, nothing you can see here. Come to the next one. See here what happens. Slightly there is some change you can see. What happens? Pulmonary during the systole is higher than the systole, but diastole is almost lower. That is the reason during the diastole, blood is flowing from aorta to the pulmonary. That is the reason I can see red, sometimes blue, sometimes red, sometimes blue, sometimes red, blue, red. That is the reason once it is blue, it is below the line. Once it's red, towards the probe, blood is coming towards the probe. See, this is, here is the catch. Remember, I told you 30%. If that, what is 30%, doctor? See, this is, take this thing from here to here. Once again, I repeat, please see. From here to here, it is systole and diastole. One cycle. This is diastole, this is systole. If the right side is more than the 30% of the full cardiac cycle, that means it is a impending, severely problematic is there. PAH is very severe. Otherwise, congenital problem should be ruled out. But in this case, Diastole is more than almost 70, what is that, 80%. Right to left is almost 10 to 15 or 20%. So it is not significant, but still it is significant. PAH is there. Now go to the next. What happens here, doctor? See, there is a some amount is there. It is less than 5%. Less than 5%. But everything is right side. Sorry, everything is from left to flow. That means PDA, PAH is there, but the flow is from left to right. Come to this. Anybody can tell me what is this? It's a pure left. Nothing I can see down. Nothing I can see down. Now I told you about the diameter. Now I told you about whether it is left to right or bidirectional. In the bidirectional, more than 30%, less than 30%. Okay, next. This is the beautiful slides. All the neonatologists performing the echocardiography should know this. Should know this. I am going to tell you. If you don't know this, then you are missing the time at where you are supposed to start indomethacin. If you will miss the time, before somebody comes, baby might have developed a pulmonary hemorrhage. Before your consultant comes, you might lose your baby. Okay, please now focus with my thought. Pure right to left is severe pulmonary arterial hypertension. Otherwise, congenital cardiac problem should be ruled out. Bidirectional shunt, 30%, I told you. Then come to the, after this, first baby will become, after the birth, it's purely right to left. After 6 to 7 hours or 4 hours, 5 hours, once the lung is started improving, it will become bidirectional. Then slowly what happens? From maximum 30%, it started coming down, only left to right shunt. Then it will either start closing. Either start, closes, PDA starts, closes. This is very important. Hold on your breath. Either it will start growing. It starts growing. So these two things I want to teach you people. Okay. Now only remember this. At the time of birth, pure left. Immediately, slowly it started bidirectional. Slowly it is only left to right. Then either it closes or it grows. This is the place you have to find out. If you are finding out, sir, it is a pulsatile or non-restrictive, then you have to start indomethacin or your whatever the treatment of protocol. Come, please now, everybody be there with me. Tell me what is this? Is it right to left? Yes. So at the time of birth, come, what is this? After 4 to 6 hours, still left side is more. I am very happy, dear. Then come down, it's very small, nothing to worry. Come down here, what happens? Sorry, this should come here. This is once again bidirectional, but left is more, nothing to worry. So here what happens? Once again, this is also same bidirectional. Left side is more than the right, but almost equal. So what happens is this one is fast. Then comes to this. It will become like this. It will become like this. Then it will start becoming like this, equal. Then slowly left side will come take over. Then either after this, either it will start closing. Restrictive means closing. Then otherwise it will become pulsatile, non-restrictive. What do you mean by these two, sir? Please, dear friends, nobody, I mean, you might have learned somewhere or you know all those things. If you are a beginner, you need not scratch and go somewhere. Please, webinar guru is teaching you. Okay, I should not tell thanks to Corona because it has killed many people, but it has made at least to learn sitting in your place. Need not come and spend lot of money. Okay, see here, systole is here. Everybody is with me. Diastole is here. Systole is also more. Diastole is also more. This is called Vmax. This is V minimum. This is V minimum. This is V max. Suppose if it is 100, this is 75. That means it is less than 2. Yes or no? Okay, come here. This is systole. This is diastole. Means PDA is becoming non-restrictive. PDA is becoming very big. Blood is flowing. It is not restricting the diastolic. Almost all the blood is flowing. So, but diastole is very small. Please see this. Diastole is very small. If it is, this is called a growing type or pulsatile type of PDA. If this is there, you should start treatment. Should start treatment provided there are two things I'll tell you. I told you diameter. I told you the LVO. If it is there, this is the place you should start. You should put where the cursor, pulse Doppler near the PDA you should put. When you press the pulse Doppler, you will find this systole. This is the systole. This is the diastole. This is the systole. This is, see, it is full body. Full body. Full body. That means what happens? PDA is closing. It is restricting even to the diastolic flow. Even restricting to the systolic. But here it is allowing systolic very easily. It is not even pushing the blood back. Diastole is very nil. So this is a place. This is called growing pulsatile pattern. This is the place you are going to treat. Please, once again, you memorize this. This is important. Right to left, bidirectional. First more than 30%, slowly less than 30% right. Then it will become pure left side. After left side, either it starts closing, that's called restrictive, or other word is closing. In that, systole diastole will come full. So that V max divided by V minimum, the ratio should be less than 2. So either it is big. So this is the place. You understood, dear friends. Now go to the next slide. So now you learned number 1, the diameter. Number 2, right side or left side or bilateral. Number 3, what is systolic velocity? Less than 2, more than 2. Less than 2 means it is dangerous. Less than 2 means good. More than 2 means very, very dangerous. More than 2 is dangerous. That's what I was telling you. Please see. Less than 2 is good. More than 2 is dangerous. Come to the second point. Now, what is this second point? LVO means since the blood is flowing more towards the pulmonary side, it has to go towards the pulmonary vein. If it goes to the pulmonary vein, it comes to the LA. From LA, LV, left ventricular is, I told you 170 ml to 220 to 230 is okay. If it start increasing more than that, that means have a caution in the preterm, provided I told you first diameter, flow, and other one. What is that other one? Growing or closing. Then LVO is increased. This is dangerous. Then LAAO, then mitral. That I am going to come to you people. Take a snapshot. I'll show you today how to do the aortic root. Please see this. If you have a snapshot, take it. Want to take a snapshot? Sir, what is this, sir? Please let me know. Sorry. This is the formula. Cardiac output is equal to pi into aortic root score divided by 2 VTI. Instead of all this formula, simplified, because pi means 3.14. So square means once again O2 4. 4 divided by 3.14 is 0.785 into aortic this thing VTI into heart rate. 4 divided by 3.14. What is 3.14? Pi value is 3.14. If you divide 3.14, 0.785. This is the formula. If you will see this formula, okay, VTI, you are going to get it. You will write. You know the heart rate, you are going to take the heart rate. then AO square you are going to measure it. You will get the cardiac output instantly. Okay, these are all the things. Please read this yourself. Where to take the aortic root? Where aortic hinges are there, values are there, that is the root. That is the maximum systole. During the systole, the maximum diameter you should take. That I'll show you. Then LA diameter also during the systole, during the diastole, where maximum portion is there, you should take. So maximum, yesterday also in my class, I was telling you, all the measurement, you should take it in maximum diameters. If aorta maximum mean will come in systole, LV maximum will come in the diastole. Please see this. This is the hinges. Hinges means where aortic this thing will catch. And LV you should measure at the tip of the mitral valves. Okay. Then if you put the M mode, motion mode, inner to inner diameter, inner to inner diameter. Once again I repeat, inner to inner, inner to inner. So number one is over. I was talking about one part is over. Second part is what is that I was talking about? What I was talking about? LVO is over. Then LA-AO ratio is over. Then pulmonary D, if you are a beginner, it's difficult, but LPA diastolic. Diastolic means what is that? First, if you put this thing, usually in MPA or LPA, usually it will become like this. Suppose if more blood is there, it will become like this. See, diastolic turbulence. Normal should be like this. It is becoming more forward flow because what happens, from aorta blood is coming towards the MPA and the LPA. So more blood turbulence in the MPA or LPA. See, this is LPA, more turbulence in the diastolic. If you take the measurement, same thing, remember, I'll show you what is easy way to remember the numbers. So no, you need not mug it. This is the EA wave. That means now you told, till now you measured about the volume overload, you know. How to do the volume overload? LV cardiac output is increased. Very nice. Then LA diameter increased. Very nice. So volume is increasing. You diagnose with the LPA or MPA, diastolic turbulence. Very good. Sir, how to measure the pressure is also increasing? Because pressure is the one, it will cause us pulmonary hemorrhage. Yes or no? Pressure is the back pressure is the one. So take, sir, do you think back pressure? Then I will go with this. Don't. First, before that is happens, that is the reason collectively you collect everything. Then keep it. Part number 1, part number 2, part number 3. ABC, ABC, ABC. So which is the max? Take it. So that is E wave. This is called E wave. Early diastolic filling of the blood from the LA to the LV. LA to the LE, early filling. A means it is a atrial contraction filling. Normally what happens, dear friends? Remember, please, if you read this, if you don't want to listen, otherwise follow with my thought. See what happens in a preterm baby. Two things will happen. Healthy preterm without a PDA. Healthy preterm without PDA. What happens? Because the afterload is slightly more. Afterload is slightly more. A will be more. But if the healthy preterm with the PDA is there, big PDA, or baby needs a ventilator care, becomes sick with the PDA, what happens? More volume will come, early blood will come to the A. So E will become more. E will become more. You understood? Like a term baby. Like a term baby. You understood? In us, on term baby, E will be more than the A. If A is starting acting in us, on term baby, that means LV is failure. But in the preterm baby, okay, because since afterload is more, A will contract the blood from the LA to the AV in healthy preterm baby. But in preterm baby, where PDA is there, E will increase. That is slightly confusion. Please, whatever I told you, read it. If you don't understand, it is difficult. One more is IV. How to take the E wave, A wave? Put the simple continuous wave near the mitral from the apical view. Put the probe from the apex view to the mitral valve and put the Doppler. You will get this. That's enough. And how to put the IVRT in between the mitral and aorta? If you put that continuous wave, you will get this. One side you're going to get the E wave and A wave. Another side you will get the aortic flow, because once the aorta is flowed before early filling, this is called ice. See, once again I'll tell you, this is you are putting from the apical view, you are putting the continuous wave Doppler in between the aorta and mitral valve. So that wave will get this portion is this portion, or this portion is away from the probe. So it is below. It's a aortic flow. This portion is towards the flow, E and A wave from the mitral. From here to here is the relaxation time. This should be more than 0.45 seconds. If it is decreasing, that means IVRT is decreasing. This is the last. I told you already what happens to the pulmonary and all those things. Please see this, dear friends. Okay, this is the time to go to the practical side. Systole. So ascending aorta will be like this. What happens later? See here what happens. This is a normal. Then later what happens? See, slightly it is going away. Means diastole is pulling the blood. PDA is pulling the blood once again. Instead of everything coming down and it should be here, it is coming up. Suppose if it is there, that is also gone. See here how much it is coming back. Means blood is pulling back to the aorta. This is descending aorta. Okay, this is once again the normal flow from the renal artery. This is go back, but it's going back. See, this is once again going back. See this is the middle cerebral artery, or whatever SMA, sorry. Okay, take this. This is AC. Normally it should be like this, but it is coming like this. If you'll see the one more thing, you will see the even reversal flow. Means blood is pulling back. Instead of going here, blood is pulling back. Systole will go, but diastole is not able to go. Since it's not able to go, it will come back. How it will come back? It will show whitish here. See here, there is no diastole only. So there is one study, sir, when I should treat. Please remember, diameter always more than 1.5 is that dangerous. Less than 1.4 to 5, see this is overlapping. 1.4 to 5 will get closed on its own, either in any gestational age. But if it is more than 1.4, please be careful. Next. Okay, range of constriction at whatever the above. Once again 1.4 to 1.5. So remember. Then what age, how many days it takes? Usually closes almost 4 to 7 days. Then this is also there, very important one. So left ventricular output, I was telling, see, no PDA, usually 150 to maximum 200. If it is this one, PDA is there, usually 170, start rising. This is dangerous. So remember this, it's more than, remember this is more than enough. Instead of all those things. And IVRT, I was telling 45. What happens in the PDA? It starts coming down. Okay. And all these things, please remember, this is the words. If you want, you can write down. Less than 1.5, 1.5 to 2. Out, I was telling you, I'll make you to remember. Write PDA diameter, one paper, please. Small, 1.5. Moderate, 1.5 to 2. More than 2. Whatever I tell, write down, sir. Then come to the PDA maximum velocity. Because if you're putting the pulse wave, you are seeing the blood is flowing above. If it is a small, as you are putting the water to your garden, if you will make that hose very small, water will jet very fast and outside. That is way. So small means, see, it is the reverse of this. See what I am telling, it is a reverse of this diameter. 2, 1.5, 1.5. Remember, 1.5, 1.5 to 2, 2. 2, this is the meter per second. Sorry, centimeter per second. Then this is also over. Come to the AO ratio. See, same thing just like above. 1.5, 1.5, 2. So I told you people to write 3 things you have written. Come to one more thing, please. LVO output. I was telling you. Remember once again 2. 2 more than 2 more than 3 more than 300. Then I was telling LPA diastolic how much it is there. How to diagnose, sir? That I didn't understand means this is the way to diagnose. I'll show you. This is the way to diagnose from here to here. Measure it from here to here maximum. It should not be more than 0.5. See what I am telling? It is LPA, end diastolic LPA, 0.2, 0.5, same. Almost it is similar to this. Means large means more blood will flow. Okay, all these things either forward or absent or reverse. Even in your exams, if anybody asks, if you'll write, almost you are filling the pages, and more than anything else, you will know what you are writing. And if you don't understand the concept what you are seeing, if you are trying to mug, you cannot remember for a long time. You will do the mistakes. Now post-operative. Please remember, once the operation is been done, suddenly what happens? Blood is stopped. Means minimal blood will come. You know what is Frank Sterling or Sterling law. So blood will start coming. Cardiac output will decrease. Then once the cardiac output decreases, it will take 4 to 6 hours to come up. In the meantime, baby might become very serious. Okay. Then IVRT, that is also very important. If it is even more than 30, but baby might not improve. That is the one you are going to, even ventilator, it might not improve. That is the time you are going to put it on either milrinol or dobutamine, whichever your protocol. Okay, next. So after all those things, we are going to see, please, my dear friends, PDA is there. I saw left to right shunt. I am very happy. Or right to left shunt. Arey daldo. Daldo means what? Start PDA. Paracetamol, indomethacin or ibuprofen. I know paracetamol or I medical legally baby will have ADHD, attention deficit, so many problem. I'll start ibuprofen. Nothing will happen. Platelet is normal. But please, dear friends, see one thing. Call the cardiologist. Call the cardiologist. Ask, request them. Is there any structural congenital heart problem is there before closing the PDA? Before closing the PDA. Okay, that is one. How you will know? If it is right to left shunt, more than 30%, if it is a bidirectional, or purely right to left shunt, it is dangerous. And coarctation aorta you should not miss. It is very easy. I think so. Probably there is a class. I'll make it easy points how you're going to diagnose. So once again, I'll tell you, please try to take before closing the PD. Okay, that is one. Thank you very much. Thank you. Okay, now just I'll sit for 10 minutes for the questions. Then I'll go for the things. Please, sir, anybody wants to ask any questions, they can ask me. Before I show the live things. Vivek? Any questions regarding the PDA? Anything you want to ask? You tell them to bring the case. Okay, tell them to just now deliver. If there is a baby, I'll show the PDA. Tell them to keep it in. Anything, sir, regarding the questions of the PDA?
Yeah, the theory and everything was very nice, sir. One small, you'll be explaining us how to put this Doppler, sir. Doppler, apply the
Sir,
Doppler.
Doppler also, I have, because without, sir, I told you,
Yes, sir.
all the first B point also,
Okay.
B point also Doppler.
Okay. Okay.
Then the LVO needs a Doppler.
Doppler, yes.
Then one more, all the gradients needs a Doppler. Then all the third point needs a Doppler.
Okay.
Anything, any questions you want to ask? I'm just repeating 1.4 is the, remember, even LA ratio, AO ratio, LA AO ratio 1.4. Okay, there are so many things are there, but try to make it instead of 1 point, catching on 1 point and arguing, make it collectively many points. It is a wiser decision instead of arrogance. It is very good. Please, because I am requesting humbly, 1 point don't treat. Take it collectively, treat it. It's more wise. Anything? Can I go for the live demo?
Yes, sir. Yes, sir. Sure.
I'll stop sharing. I'll go to the live demo. I can hear their voice. If anything wants to, huh? Can I go there? Can very nice. Thanks to my people. They bought one baby. They bought one baby. They bought one baby. I'll try to show you people. See, this is the probe I'm going to use. This is the probe I am going to use. Before that, I'll try to clean the probe. I'll try to clean the probe because it is a must. And I'm going to, I told you, I'm going to change the pediatric. I'm going to change the probes. This one is a neonatal. Okay. And I'll change it S12 to 4. S12 to 4. And I told you because this is first I'll, before the baby cries or anything, I'll try to show the PDA. And I told you there are two things what you have to know, dear friends. I washed my hands. Okay, I washed with even sterilium. I washed even the probe. I washed even the probe, and I am very clear. I am very clear. Okay, I am going to see only PDA. I know that. Okay, this is the new. I didn't see any other things before baby is getting up. I am putting the gel, and I have turned it. Now, please come. Now, very comfortable. Okay. See dear friends, you can see off the light and then you put the air. Okay, come here. This is the way I am. This is the pro. I am going to keep the pro in my left, I mean my right hand. I should not move, so I have told myself that that's more comfortable. At the same time, I'm keeping like this because I should have a perception of the skin where I am keeping the probe. And I told you I left parasternal. Okay, I left parasternal view. I am trying to show up the
Sir, sorry to interrupt. You are not visible, sir.
stop very slowly. Okay, you can see very clearly the parasternal short axis view. I'll go slightly up. You can, I'll put the color. I'll put the color. I think so. It's a morning baby delivered. Morning baby delivered. You people can see the flow. You can see the. Okay, you people can see the flow. Okay, see, you people can see. Once again, I will show. Nidana, Nidana. I'll remove the color. Once again, I'll remove the color. I left parasternal. I know that I'm showing you the high parasternal. Now I am opening the almost a PDA ductal view. You people can see the duct also like this. You people can see I'm turning. See this where I can open the PDA. Okay, it's very nice. And if you want more clarity, I'll take the other probe. I'll show you. This is a neonatal. Since the baby is big, I'll take the pediatric probe. Once again, I wash the probe. Once again, I wash the all the things everything you should have the patience. Yeah. Just see, dear friends, now. Once again, I'm taking the pediatric probe. I'm trying to show the things. Please see there. See there. I'm turning slightly this side. See, I can show you all the pulmonary veins. Okay. I can see now, see the PDA. You can see left to right side. At the same time, you can see some blue color also you can see. Yes or no? It's very nice. Okay. See, this is what I'm showing you in the probe. Please see this. This is an aorta. This is an pulmonary artery, main pulmonary artery. This is RVOT, right ventricular outflow tract. This is the PDA where you can see this is more than 6 hours baby. So it is see left also you can see, right also you can see. It's a bidirectional shunt. Okay, now you are able to see one is high parasternal view. Now come here. Once again, I'll show you people how to keep the probe. This is the probe. This is the marker. I am keeping the probe on just above the nipple and like this and okay. And see this. Yes. Now, see now. I'm able to upside to open up the PDA. I have seen the main pulmonary artery and I am showing you cursor left pulmonary artery, right pulmonary artery, aorta, RVOT, LA. Okay, this is LA. This is RA. Now come to this. Okay, I'm turning slightly. Now I am able to see the PDA slightly. Please check it yourself. Then put a color. It's a big PDA. You can see very neatly. Okay. And in between, you can see the bluish color also. So this is the PDA. I'll freeze it. And once if you'll see this is an aorta, ascending aorta. If you are seeing here, what you are seeing here is a PDA. Okay. And sometimes it looks like a blue. See, it's a blue. Sometimes it's a red. Sometimes it's red. That means it's a bidirectional flow is there. So how to diagnose bidirectional flow? Now you have seen the cup and saucer slightly up above left parasternal. Then immediately you have put the color. Now I'm going to the color once again. I am putting the either pulse wave I am showing you the PDA. I am putting the curve. Very clear. Very clearly, I sometimes blue, sometimes red. It's a bidirectional. I am putting the power Doppler now. I'm putting the power Doppler. You people can see now it is a once again I'm putting the cursor. Please see this. This is all the left side. This is all the left means right to left shunt down. This is all the left to right shunt. This is left to right shunt. This is right to left shunt. Then take the measurement. Take the measurement from here now. Okay. Take it till the next one. Till the next one. What is this? This is the next one, whatever it is. Okay, take it till here. Okay, this is how many seconds? Time is 0.520. You people can see time is 0.520. Okay, now select. Now, after, sorry. Okay, enter. Now I want in 0.560, I want to see once again caliper. Only right side I need. This is right side is right side once again time is 0.5. Almost it is 50%. You can see this. You can see this. This is a 50%. You can see 0.250. The second one what I took. So that means 50% of the time. That means PAH is there. This is a common for the just now delivered baby. Okay, more than that. Suppose after that if there is something, now you have to see how to see the pure left side, pure right side, and bidirectional, whether it is more than 30%. Neonate immediately within 6 to up to 14 to 16 hours, it will be having slowly from pure right to left, it is coming towards the bidirectional, bidirection more than 30% start coming down to the less than 30%. Now you have seen this. Now what you have to see? You want to see the measurement. Oh, and the measurement. This is, please, dear friends, once again, I'm keeping the probe. I'm showing you this. Please see this. I can see myself, the PDA very clearly. I can see myself PDA very clearly. See this. I am showing the cursor. This is MPA, main pulmonary artery. This is aorta. See, I can see one here, left pulmonary artery. I can see here. Can you people see this? Now I put the color. Wait. Sorry. The PDA. Now I am worried. Where should I take the measurement, sir? This is 1 day old baby. But however, see this. I can see something. This is the place where my cursor is there. See, just see this clear. Yeah. Now I am seeing. I am removing the color. I am removing the color. I am finding the PDA from here. I can see the gap here. I can see the gap here. Okay, I'll put the color. See this color. This is the PDA. How to measure the PDA? I'll remove the color. This is the one. So you people can see more better way. Please, can you come, sir? Here. See, this is the way PDA. Very small. You people can see. Where my cursor is there. I'll put the color. Okay, I'll put the color. Now measure it. Measure it. From here, come to this. Small 1.4 definitely term baby. In 4 hours, it's closing. Okay, now put the color. Go to the other page. You need not do much. You can see where it is flowing. Now take the measurement. In the color. If in this it is more than 3 millimeters, because here the color is unleashing, means it is coming outside of that whatever the PDA is there. Because what happens, it needs some more thing. Again, if you will decrease or increase, what happens? It will come down. That is the reason PDA, when it is PDA, if you put the more color and the gain, it will be having the problem. So with color, without color, both you should take. You yourself slowly you will get it, dear friends. One, I showed you the diameter. Once I showed you now the bilateral direction. Then I showed you about whether it is what type. Still, it is not a closing type or it is not a pulsatile type. That I cannot show you. Number 1 is over. Then come to the cardiac output. How to see the cardiac output? Then LPA. Now come to the LPA flow. I will show you how to diagnose LPA. Can you come here? Can you keep it? Once again, keep the probe into the same place. Can you come there, sir? Same high pattern. You are coming to the MPA. Yes or no? Yeah. When you are coming to the MPA, when you are coming to the when you are coming to the MPA, put the color if you want. You are putting the PDA with the color and put the pulse Doppler to the either the MPA or LPA, wherever you like. Okay, you are putting. Now, I want you people to see. See, this is during the systole. What about the diastole? See, it is more, very high. So I want to take the measurement. I'll take, this is how much? The maximum velocity is 0.75. So that means a big PDA is there. It should be less than 0.5. 0.5 is the maximum. 0.3 is the moderate. 0.2 is very minimum. So it is 0.75. Okay, if you don't want to take that, clear, go to the other one. See here, I'm taking, because this is a systole, this is a diastole. See here, it is more. Yes or no? That is the reason the velocity should be less than 0.2. It is 0.3. Is it difficult now how to take the measurement from MPA, LPA in the diastole? Now you understood. So now come to the cardiac output. Okay, how to take the cardiac output? First, you need the heart rate. Okay, the machine itself will give, but I did not install and I don't want, because my people should learn their own how to do it. Now come to the this thing LVO, how to take, but that is I am going to show you in another class. But however, I should show here, I'm showing you. Now come to the LVO. So this is, I am always, I told you, I am going to see the heart always in my anatomical position. So one thing, what you have to see is, dear friends, always remember, my intraventricular septum should be always comes to this apex. Then only I will get the maximum. Okay. See, this is a very beautifully, I am getting the 4-chamber view. See, you can see the 4. It is moving. Okay, 4-chamber view. I am coming. One moving. Okay, 4-chamber view. I am slightly scooping up. I am opening here the aorta. Once I am opening the aorta here, that is called a 5-chamber view. You people can see this. Okay, opening. Then put the pulse Doppler there. I have taken this. Now what should I do? I should put the tracer. In this tracer, I should measure the caliper, not caliper, sorry. Then select. Tracer, select. Tracer, sorry, clear. Okay, first, once you achieved this is the way, you are very happy. At least you are coming to know very good cardiac contraction is there, because it should be more than 0.9. Almost it is coming. The flow is coming more than 1. Now come and in your machines, whichever the way the company people will tell, you do it. Press the tracer, then come to the select, and after selecting, okay, tracer, come to the testing. Come to the select, then very carefully you should measure it. See my hand, it's a ball and this thing. See my hand, please, dear friends, very carefully, because we are neonatologists, we are not echo technicians. Okay, please see, dear friends. How much is VTI? 15.4 centimeter. 15.4 centimeter is the VTI. It will come more than 16 because I didn't take much here. Okay, see, it should be coming from this angle, the VTI. It should come like this, and you should take it completely. This is VTI. VTI is, please write down, somebody, one white paper. Take somebody, take white paper, you take the calculator. Okay, now VTI will be 15.5. VTI 15.5. 0. Please take it. Everybody, dear friends, take your paper and pen. VTI 15.5 centimeter. 15.5. Now come to the heart rate. How to do the heart rate? Okay, make like this. Come to the time. So from how to take the time from here to the next cardiac cycle. See, this is the next cardiac cycle. How to do this? See, this is from here to the next cardiac cycle. What is the time is 5.40. Please see this. This is time is 0.540. 60,000 divided by 540. 60,000 divided by 540. How much? So 111 is the heart rate. So 60,000 60,000 60,000 divided by 540 is equal to heart rate. Otherwise, your monitor also will show the heart rate. Monitor will also show the heart rate. Now 111 is the heart rate. VTI is over. So now you should measure the aortic root chamber. Now I am going to measure the aortic root chamber. How to measure the aortic root chamber? How to measure, dear friends? I was telling you how to measure. Once again, I am going to 2D. I am coming to the up and down. See, once again, I am going to up and down because the marker was here first. Now marker is here. Okay. Now I am pressing the log. See here what I am doing, dear friends. This is the long axis standard. Please see this. You people can see where is the hinges of aorta. This is the aortic hinges. And I am taking the maximum diameter because this is opened now towards this. That means blood is flowing from here to here. Now I started measuring from here to this place. So how much? 0.631. So please measure it. Now write down. Okay. See, here only machine will tell. Why I am not telling machine? You should learn. You should learn. You should learn. Now 0.785 into AO2 into, okay, what I told, VTI into heart rate. So 0.785, you take the calculator, Tejasvi, come here, take the calculator. Into 0.631 into 0.631 into VTI is 15.5 into heart rate is 111. Now, what is the cardiac output? $537. So, what is the weight of this baby? So now, approximate weight is
3 kg.
exact. Correct weight test. Weight test. 2.84. So can you, what is it? See, 189 ml per kg. So now you came to know 189 ml per kg is the, what I told you, it should be more than 170 ml to up to 300 ml. It is exactly same. Okay, that is the way you should diagnose the cardiac output. Now you understood, dear friends, how to diagnose the cardiac output. Now you understood the first one, sorry, what you understood is, the first one what you understood is diameter. Okay, millimeter, how much? The second one what you understood is whether it is bidirectional or right to left, otherwise left to right. Then come to the whether it is closing, whether it is pulsating. That one closing or pulsating. That will come because it's not become baby. It's almost it's still there bidirectional. It's not come. Tomorrow, if you'll see, or evening, if you'll see, it will be happening. It's first you have seen. Second, in the volume overload, LVO you have seen. In LA-AO ratio. LA is to AO ratio, how to see. Now I will show you that. Then come to the LPA. Diastolic or MPA diastolic. It should not be more than 0.2. Here it is 0.785 because it is PDA is there. Then last one is either ascending, what is it? Anterior cerebral artery diastolic flow. Otherwise, it's in the celiac artery or SMA because it should be like this. Okay, it should be like this. Suppose if it is not like this, if it is coming. So either if it is coming, this is called absent diastolic flow. It is called a reversal diastolic flow. It should be like this. That also we will see. In all the things it is. This is normal. This is absent diastolic flow. It is reversal diastolic flow. Now we will take out this. Now we are going to do this. How to do it? Please. Thank you. Already I can take it here also. See here. We will do once again. We will take. Please. I am doing it. Parasternal long axis. I have done the parasternal long axis. Hinges also I am seeing. Okay, either two way. One is 2D way you can see, or M mode you can see. Put the M mode where you should see near the hinges. See, this is hinges. Where my dark mark is there. Hinges means where aortic valves are holding to the aorta. That is. I stopped it. Now come to the maximum. Can you help me? Okay. Now come here. LA ratio. LA means calculator. So LA ratio, I am going to do it like this. LA ratio near the systole. LA ratio is 0.986. 0.986. Okay, divided by AO. Now I'll go to the AO. Anywhere, whichever the maximum you can take, I'll take from here. This is 0.476. How much is this? 0.476. See this? Understood? It is almost 2. Okay, as the time progresses, slowly it comes down. Anything, if the preterm baby, how to show, I showed you. Okay, in the M mode, I showed you. Either you can do in 2D mode or you can do in the M mode. Okay, same thing. If you will keep the, see, you are able to see this. Then you are keeping the. I'm keeping now M mode in the. Baby is having the tachycardia. Baby is crying. How to see the LV-AO ratio? LV, you should see this. Here the mitral valve. This is the one mitral valve. This is the one mitral valve. Mitral valve. Okay, near the tip of the mitral valve, if you are seeing, then measure it. Put the M mode. M mode, if you are putting, this is the only thing where my cursor is moving. Please see, dear friends. This is maximum diameter from here to here. LV. Then AO, once AO means aortic root. aortic root where it is there also you should take one measurement. Okay, then compare AO elevation. It should not be more than 1.6 to 2. So that is the way volume overload you have seen now. Now come to I am going to do the pulmonary. Now that is a pulmonary overload. How to see? I showed you. Now I am going to systemic vascular stealing. How to see it is stealing is once again, dear friends, ascending aorta. How to see the descending aorta. How to see the descending aorta? Put the probe. Say anything. Let the baby be comfortable. I am very happy. Till now, we are getting all babies are good, quite very, very happy. Thanks to my postgraduates. I am going to see where to keep the probe. You see now, where is aorta? Root of aorta. Now you are able to see root of aorta, yes? So this is the one. This is the one, ascending aorta, arch of aorta, descending aorta, where black you can see is the RPA. And this one is the innominate. This one is the innominate. This is the subclavian, sorry, left clavic, what is this? Carotid and the subclavian. See now, this is the place. I don't think there is anything. Now I am putting the power Doppler. I am putting the power Doppler. See, I am not finding everything is towards, there is a PDA, but it's still bidirectional. I can see only one few little, it's stealing, but everything towards down only. It's going to the systemic. See, this is a systole, this is a diastole. Once again, I tell you, this is a diastole. If it is absent, it's coming up and going from here to here. See, there is very minute thing is there going towards the stealing. That means PDA is almost, it's closest, nothing to worry because as I said, term baby is closest. This is the way you are going to see in the descending aorta. If it is PDA, PDA is there. If it is stealing, this diastolic flow will go to the airport, or it will become first absent, then go to the airport. So now you understood in the ascending aorta. Now you know where I am. Aorta. Okay, this is where I am putting my probe is towards the arch of aorta. Now go to the what happens to the brain. So almost PDA, I think the working we have done PDA itself here. Now I'll go to the ACA. ACA means arterial. Okay, now I am going to see the ACA. For that, from cardiac mode, I am changing to the other mode. See, from cardiac mode, I am changing to the what is it? Pediatrics. In the pediatrics, I am going to the brain. Okay, it has changed. See, you can see it's a neo head. Okay, I'm changing the probe because I need a curvilinear. This is called a curvilinear probe. I cleaned it. Then I am coming to the brain. I am seeing from my left hand where is AF. It's very small. I am putting the probe. Can you people see this? Yeah. Yeah. Please show them right now. showing you people the brain now. Light off, madam. I'm showing you the brain now. Putting the color. Yes. Okay, we'll show you another baby. Baby is moving too much. Okay, I'll show you another thing. Moving too much. Now we will go to the other one where ACA. Then come to the celiac artery. Please come. I'll show you to the celiac. I'll take to the abdomen. Now I'll show you to the celiac. This is the place where I am keeping. Okay, this is the place where my probe should be towards the head. I'm keeping in the abdomen, and you people can see now. You people can see what is that where I am placing. Okay, see, you can see the what you people are seeing now. Please, I want your explanation. What is this? Two things. This is abdominal aorta. You can see celiac artery as well as the what is that artery? Yeah. So that artery I want to see, and I am doing the angulation here. see this. This is the beautiful artery you people can see. I am now started focusing and I have done the angulation perfectly. People can see there is not even one little diastolic absent flow is there. Suppose if it is, this is a diastolic flow, there is no absent or there is no reverse. There is no reverse. That means this is the way SMA artery or celiac artery you can do. In this place where you can see that what is that absent, that is more dangerous. Now I showed you whatever I told you, I showed you. Now come, there is one nice case is there. I'll take only 3 minutes. I know now it is. Okay, light, can you put the light? Because I don't know. See, this is the 5th time in my life, probably okay. Slowly. Okay, now please hold on. Okay. I am happy now. Some more. I washed my hands. I didn't touch any blood or anything, just to the probe. However, see, this is the case has come from some ex-hospital. Baby was very bad. Be careful. Very bad. So, yeah, severe problems were there. Please check it once again. This also I cleaned the probe. I cleaned the probe. Can you put? I'll take only 10 minutes to show you, because if this baby, I don't think it is really difficult, but we will try to make it. And you people should diagnose what it is. And there is lot of things are there. We started Milrenol and we started Dobutamine. Later baby started improving. Please be afraid. Can you catch this? No, here. So PI. So pulsatility index or perfusion index was 0.1. The BP was 110. Okay, but baby was in shock. 110. Baby was not in cold. Baby was not in cold at all. Cardiac output was only, it is 86 to 90. Number one. Number second, FS means fractional shortening was very low. It is 17. 17. PI was low. I want PI to all my babies more than 0.7. More than 0.7. Heart rate is now normal. SpO2 is 97. So how to diagnose afterload or preload? That I will tell you in my next class. Next class, how to diagnose the afterload is more or not. Now come to this brain. Please, dear friends, it's a nice place for the learning people, for the baby to start with. Okay, please see this. Anybody can tell me what is the diagnosis? And you people were asking me about the PDA. I'll show you the PDA. Our doctor. Okay, anyhow, anybody can tell me what is this view? I think so we are going to talk about this soon.
Sagittal.
Okay, we can tell me. Now I am going towards the baby's right side. Just see the right side. Any problem? Anybody can diagnose what is there on the right side?
What is IVH?
Once again, I'll put. So I'll come from the mid sagittal. Anybody now? It is right grade 2 to almost grade 3. Grade 3 IVH. And 2 days back, this baby had a severe choroid plexus here, severe choroid plexus hemorrhage. It was retracting the choroid plexus. This hemorrhage is gone here and retracting the choroid plexus. Okay, now you can see the choroid. You can see the hemorrhage here, and hemorrhage was here. It is resolved. Now you have seen the hemorrhage. How to diagnose hemorrhage? We will go to the next class. Now come to the left side of the brain. Yeah, anybody can diagnose what is this now? It's still the left side of the ventricle. Choroid plexus is lobulated and the hemorrhage was there. It is resolving gradually, but it is there and it is retracting. It is retracted. This is very, very dangerous. Now this is one is over. I'll come to the heart. This baby, just I want to show you the abdomen IVC of this baby. I have put the baby on HFOV. That is the reason you are seeing it is shaking. And see this. Aorta is distended. You can see the. Anybody can tell me what is this? What I am seeing? What I am trying to see? IVC. The IVC was almost. It is dilated like one big channel like an aorta. Now it is almost. I'm very happy about the aorta. Okay, compared to morning, it's better now. Okay, so you are seeing the IVH with the convulsions, come with a history of shock, with the pulmonary bleeding, with the gastric bleeding, and put on HFOV, pulmonary bleeding stopped at the same time. Okay, gastric bleeding, we have given the FFP platelet was 20,000. Now the severely, it was shock, but with all these things, baby had severe afterload is increased, but baby was not cold. Okay, this is one catchy point. Okay, catchy point. We started Milrenon with the dobutamine. Baby improved. Lactic acid was 7. Lactic acid was 7. Now it is 0.5. Why I am telling is, actually echocardiography will save the babies. Okay, number 1. Next class I will be doing little PPHN and other things. We will go to the class. Just let me take. I think people can see me.
No, sir.
No, 1 minute. Can you see us?
Yes, sir.
Please, now if you want anything you want to ask me. Yes, please. Almost in PDA, everything I showed you people.
Yes.
Any doubts, anything you want to ask me?
You can unmute yourself and ask the doubt one by one. Please unmute yourself and ask the doubt one by one.
Between a term and a preterm PDA, is there any difference in echo, sir?
Echo, absolutely no, sir. Absolutely no, sir. PDA is PDA. 99% within 4 hours functionally it closes, sir. I'm not talking theory, sir. We have seen. Now almost it's closed. Nothing, everything is normal, sir. It's how many hours? 5 hours, baby, sir. You have seen it's almost closing. There is no difference. Only thing, if it is opening, if the PDA is opened in a term baby, probably please search for either collagen vascular disorder or kidney problems, or probably there is, I'm not talking theory, sir. Just I'm telling you, look for some chromosomal problems. If there is persisting, unless otherwise congenital cardiac problem needs PDA to be survival. Either left to right or right to left.
So that's it for PDA. I am just one question. So for you, whenever you make a diagnosis of a PDA in a preterm, in addition to seeing the PDA, the diameter, the flow and the velocity, then you must look at the pulmonary circulation, whether there is increased pulmonary circulation, whether it is left to right or right to left shunt. And for that, you told us the various calculations, sir. IVRT, then EA ratio.
Show you IVRT, I have forgotten. If
Yeah.
okay, time is over. Next class, I'll show you IVRT also.
Okay, sir. And the last one is the
IVRT. Sorry. Okay. I'll
Okay,
show you. It's easy, sir. Even E also next class I'll show you.
Okay.
In the ventricular function is there. Next class, because next class is PPHN. That
Okay.
next class is a functions how to calculate. In that I'll show you EA and AV. Even we can get the baby also. I will show you, sir.
Then regarding the systemic, diastolic steel, should we, whenever we want to confirm or demonstrate diastolic steel, we can do at any one of these places, sir. Superior mesenteric, celiac artery or
SMA,
cerebral artery.
down anywhere you can do. Up there is ACA, you can do anywhere, sir.
Okay, sir.
Sir, one small doubt, sir. It was a great presentation. I just wanted to know, when the baby is ventilated, the window becomes 4 and there would be a lot of lung overshadows. In such place, which is a better view to see PDA, or is there any technique where how to expose PDA in those babies?
Sir, even now also we have seen one thing, sir. Remember, if it is HFOV, you are putting baby for some other reasons. 90% in PDA nowadays. Okay, I have seen in Japan, the people are putting on the first 400-gram babies HFOV. They are more embracing that. And whatever today I taught you, sir, maximum things I learned and I got a inspiration from Japan. Because they are saving 400-grammer baby, they are putting on HFOV for all the baby. I am not telling we should follow. And they are diagnosing afterload too. Because I was not knowing how to diagnose even afterload also. And I learned from there. And for your question, if the lung is, that I'll teach you later, sir, how to diagnose the afterload, because LOV. Then if the lung is hyperinflated and PDA, sir, 99% anterior portion of the, heart, RA and pulmonary artery is maximum towards the anterior side. And if you will go to the suprasternal, where I showed you pulmonary artery, sir, 99% in my 30 years of life, I never missed, sir. That means probably what you are asking, hyperinflated chest and it's not missing. I don't know, sir. Because even congenital diaphragmatic CLE, lobar emphysema, where left upper lobe is more commonly involved, there also we diagnosed this part, sir, even after 3rd day. I don't think, sir, because it is easy, sir. In my knowledge, I don't know, sir. I don't know about others, sir.
Sir, all these values holds good even when a ventilated baby. When there is, okay.
Sir, very easy. So I told you to remember. That's what I teach my postgraduate. 1.5 to more than 2. Then 0.5, 3 is 0.2. So it's very easy, sir. Even the IVRT 30, 40, 45 is everything holds good, sir. Because they have studied from almost 600 grammer to up to 1.8 gram. Almost everything matches. Just it is 0.3, 0.10 up to 0.10 varies. But it is and inter-observer problem only LV left atrial diameter or left ventricular diameter only varies with inter-observer. Means suppose you have done it today or now you might have got, I might have got, because it's all depending on the shunt PFO and AST or PDA. It's all inter-observer and cardiac rate. Otherwise, everything is almost same, sir. And books are given multiple things. Whatever today I told, it is practical. That much is enough, but at least that much you should do. Sir, anything, sir? Sir, even next class PPHN will be there. I don't think PPHN case is there with us at present. If there is a case, I'll try to get it, but I'll make PPHN case also very easy. Only 5 things to remember. That is enough. Instead of there are more than 101 signs, 101 things, make it 5 things. It's more than enough because we are NPE, means neonatologists. We are performing the echo. That is enough. We are, if you will learn, trust me, we are far better than any technician. Any pediatric cardiologist are more better than adult cardiologists. But however, we should know our limit. We should call them whatever we know. Kamal sir?
Questions? Can we close the session for today?
Yes, sir. With your this thing, sir.
Thank you, sir. Thank you so much. A lot of effort has gone into your preparation today, and it was very interesting, sir. Now it makes us go and use the your transducer in the ward and use it and see our findings for us. I think that will make us more competent. As you said, if we do 750, we can call ourselves okay. Some are not competent in doing echo. So that is really keeps on ringing in our ears. Your words. If you do 150, you are sort of okay. If you do 750, you are competent.
Sir. No, sir. Because of you, you are stimulating everybody. Because when 15 years back, when I was talking about the echocardiography and ultrasound in one very big conference, people have told me he is one, like that attitude. Now everybody started embracing.
Yes. Now they know it
So,
is like one more, like having it. We use this more than the stethoscope. In newborn ward, we use the ultrasound transducer more often than the stethoscope. So it has become an essential tool to day-to-day management of
no,
newborn.
encouraging your postgraduates, sir. Really, hats off to you, sir. Hats off to you.
Thank you, sir.
I'm not praising you, sir. From my heart, really, I am praising you. Thank you, sir.
Thank you so much, sir. And we'll call it next day. Next class will be next Tuesday. Is it not, sir?
Next Tuesday, 2 o'clock, we will start.
Yes.
Then we will end early.
Yeah.
A PPHN.
PPHN.
Okay, I'll bring and show PPHN, sir.
Yes, sir. PPHN.
That
Thank you,
next
sir.
class. That next class we are going to do about all the how to do the ventricular function is good during the systole, during the diastole, and what is global function.
Yeah. Hello.
Function. Everything we will teach, sir. Okay, sir. Bye, sir.
Okay, sir. Bye, sir. Thank you. Thank you, everybody, for the patient watching. Thank you.
Thank you,
Right.
Thank you, sir. Thank you.